Physiologic response to various levels of pressure support in NAVA and prolonged weaning. Pressure support ventilation is an assisted mode of ventilation used during weaning processes. It provides a decrease in worker breathing and inspiratory muscle effort. Inspiratory muscle effort can be reduced or almost totally eliminated, depending on the level of inspiratory support. Prolonged unloading may lead to respiratory muscle atrophy and subsequent weaning difficulties. Pressure support ventilation is characterized by a unique combination of simultaneous, spontaneous, and mechanical breathing, so that the ventilatory and flow rates and tidal volume depend on the patient's breathing pattern and the set of level of pressure support. Merely adjusted ventilatory assist is a form of partial ventilatory support where the muscle applies positive pressure to the airway opening throughout each inspiration. NAVA utilizes the electrical activity of the diaphragm, which is the best available signal to estimate the respiratory drive and to trigger on and cycle off the delivery of mechanical assistance and regulate its amount. With NAVA, the patient retains full control of the breathing pattern. NAVA is efficient in unloading the respiratory muscles and maintaining adequate gas exchange while improving the patient-ventilator interaction. Diaphragm electrical activity allows one to monitor the patient's respiratory drive and their ability to meet the increased respiratory demand. Diaphragm electrical activity represents the neural drive to the diaphragm. The activity is captured, fed to the ventilator, and used to assist the patient's work of breathing. As the ventilator and the diaphragm work with the same signal, mechanical coupling between the diaphragm and the ventilator is practically instantaneous. In this article, patients that were studied were all tracheostomized conscious patients that had difficulty weaning were considered eligible. Prolonged weaning included failing at least 3 attempts or requiring more than 7 days of weaning for mechanical ventilation after the first spontaneous breathing trial. 14% of these patients have prolonged weaning in the ICU and have a high mortality rate of 32%. The patients excluded from the study included those younger than 18, gastro and esophageal complications, hemodynamically unstable, possible infections, mental impairments, and those not willing to participate. 13 patients were used for this study. This table shows the demographic, physiological, and clinical characteristics of patients during the study. Some patients were on mechanical ventilation for a minimum of 10 days to a maximum of 117 days. This figure shows ineffective triggering between NAVA and diaphragm electrical activity signals. Ineffective triggering were recorded in the last 3 minutes of the recording of the highest level of assistance by ineffective triggering index. This calculation included the number of ineffective efforts divided by the total respiratory rate. Dyspnea was also assessed by using the modified Borg scale along with heart rate and pulse oximetry. The authors assessed the physiologic response to varying levels of NAVA and pressure support ventilation within 13 tracheostomized patients with prolonged weaning. Each patient had 8 trials at 4 different levels of assistance, either in pressure support or NAVA. Increasing the level of assistance resulted in a tidal volume increase in pressure support, suggesting that NAVA reduces the risk of overextension. Tidal volume variability was higher in NAVA compared to pressure support and increased when the pressure support level decreased with no change according to the level of NAVA. Inefficient triggering was similar in both groups. Level 1 is a high assistance. Pressure support used the lowest inspiratory support capable of achieving a value of less than or equal to 2 on the modified Borg scale without any sign of respiratory distress. Level 1 for NAVA was determined using the NAVA preview function. Level 4 is low assistance that had a reduced inspiratory assistance associated with a greater than or equal to 6 on the Borg scale. Level 2 and 3 were moderate assistant levels of ventilatory support. Each level assistance was studied for only 5 minutes, then back to their normal vent settings for 20 minutes before going to the next level. This figure shows a relationship between tidal volume and diaphragmatic activity using EAD peak at each level of assistance. Both NAVA and pressure support ventilation reducing the level of assistance produce an increase in peak EAD and reduction in tidal volume and minute ventilation in pressure support ventilation, but not NAVA. Peak airway pressure decreased with every reduction of level of assistance with both NAVA and pressure support ventilation. Variable tidal volume was assessed by coefficient variable, which showed an increase in reducing the inspiratory assistance in pressure support ventilation only, and at each level resulted higher in NAVA than in pressure support ventilation. Borg scale at the lowest level of assistance didn't differ between either NAVA or pressure support ventilation. This data showed that reducing tidal volume by decreasing the amount of inspiratory assistance and pressure support ventilation produces a significant fall in asynchronies between the patient and the ventilator. This was the first work to titrate NAVA according to two major respiratory signs, dyspnea and respiratory distress. NAVA is shown to eliminate risk of overdistension, and expediting weaning using NAVA and EAD monitoring needs further investigation. Some limitations in the study was that the study didn't use ABGs after each trial due to the fact that they would have to poke the patient 8 times to obtain the information, due to the lack of supplies in the rehabilitation center the study was taken in. But SpO2s didn't change in the patient throughout the study. Measurements were performed only after 5 minutes for each mode and level of assistance. The lack of additional time could be criticized as not being enough time to earn sufficient results. Prolonged weaning may depend on different causes and be related to increased respiratory load or reduced muscle. Diaphragm electrical activity and its feedback control were preserved to titrate NAVA for up to 3 days. Regardless of their disorder, they were able to study all patients. Although in prolonged weaning, patients with postoperative diaphragmatic paralysis, it would be impossible to use diaphragm electrical activity and NAVA. Questions after reviewing this article. If measured for longer than 5 minutes, would results still be the same if the patient were to tolerate it for longer? What kind of patients do you think NAVA would not be beneficial in? Why do you think SpO2 is measured but not ABGs? What did you learn from this article review?